Next, we'll call Dr. Suman Kumari MEENA. She's presenting congenital eyelid eversion, the quandary of whether to delay intervention.
Thank you so much. I would like to thank APO for this opportunity. I'll be presenting this interesting case where an infant came to us with congenital upper eyelid eversion. I'll be taking you through this in 4 segments. So this 8-day-old child came to us, bought by his father and grandmother, with a complaint of bilateral upper eyelid eversion, which was present at birth. He was born at 34 weeks of gestation by normal vaginal delivery, and the antenatal period was otherwise uneventful. Antenatal scans did not show any trisomy of 21. The only thing identified was oligohydramnios at 32 weeks of gestation. He was referred from Kota, Rajasthan with topical lubricants and antibiotic drops. So on examination, there was no dysmorphic feature and pediatric evaluation suggested no systemic abnormality. Coming to local examination, we could see that both the eyelids are reverted with severe chemosis and serosanguinous discharge with crusting. There was no anterior lamellar shortening. Rest of the anterior segment and posterior segment examination was within normal limit. So now the options were whether to manage conservatively or consider surgical intervention based on the amount of chemosis. The options for conservative management were lubricant, antibiotic, and saline so gauze application, whether we use normal or hypertonic. In surgical, the options were to mechanically reposition it, temporary and do temporary tarsorrhaphy, or apply compression suture or skin grafting. So how we manage this child is we used paraffin gauze and we used ointment, uh, hydroxypropyl methylcellulose, chloramphenicol, and hypertonic saline ointment. Along with this, we added cold compression and we did a upper lid massage from above downward. So the treatment response was that child started showing response by day 3 of life, and by day 9 we could see there was a significant reduction in the amount of chemosis. So we discharged the patient on day 9 of starting the treatment and asked to follow after 1 week. At day 16 we could see that on conservative management, left eye has completely improved and right eye, while opening his eyes, the chemosis has reduced. When he was crying, the eversion was coming, but otherwise he was able to open his eyes. So at 1 year follow-up, we can see there is complete resolution of the upper eyelid edema. Since the patient was from Kota, he couldn't come for follow-up, so we just contacted him on telephone. Coming to the discussion part, on PubMed search, I could find 54 results with the first very report in 1896 reported by Adam. Since then, 54 reports are present, and it is frequently found in association with Down syndrome, with 15 patients being reported. The other associations identified as collodion skin disease, which is a ichthyosis, and it is more frequently found in Nigerian population. The proposed hypothesis is whenever there is a prolonged or obstructed labor, it causes eyelid eversion and thus lead to orbicularis spasm, which acts as a sphincter, which causes strangulation of conjunctiva and edema. This strangulation causes venous stasis and thus further chemosis and conjunctival prolapse and creates a vicious cycle of continued eversion, sphincter, further spasm, and venous stasis. So all the reports which I went through, I found that majority of the patients were managed conservatively, and the aim of management was to prevent conjunctival desiccation and infection by using lubricants and antibiotics. Along with that, reducing the edema early by saline soaked gauze and over the prolapsed conjunctiva. Only very few required surgical intervention, where even manual reposition on day 1 mostly failed. It was only successful when it was slightly reduced with topical lubricants and saline soaked gauze paste. Some had also tried subconjunctival hyaluronic injection. So the take home message is that the goal of treatment should be that you prevent the conjunctival injury by preventing the desiccation And for most of the patients, wait and watch, consider conservative management, and consider surgical intervention only if they are non-responders or there is chronic edema present. Thank you very much.
Thank you, doctor. That was well managed in the end. But tell me, up till how long would you have waited? You waited for 9 days and then discharged.
Yes, ma'am.
How long would you have waited? Was there any end point in your mind when you would say, "Okay, now we have to intervene"?
Ma'am, actually, whatever reports I went through in the earlier days, what they used, probably because of the amount, we think that intervention will definitely help faster. So people who did compression sutures or lid sutures, the result came within 2 days of doing the compression. But with conservative management, the response came within a week, but by the time complete resolution happened, it was 4 weeks time. So based on all the literature study, I suggest that if the response has started within 1 to 10 days, it is good that we manage the child conservatively and wait for 4 to 5 weeks. If there is no response by 2 weeks, then we should consider surgical intervention in the form of temporary tarsorrhaphy or hyaluronidase injection or compression suture.
I have one suggestion, like before concluding, like when to intervene surgically, you should have whatever you have recommended in one case, you should have series of cases. And then only you can recommend like how long you should wait for surgical intervention
Yes,
and all. Based on a single case, you can't recommend anything.
yes, ma'am.
That is suggestion
I
from
was
my
asking
side.
her, in her case, how long would she have waited?
Ma'am, since the response came within like 3 days of starting the treatment, so we continued the conservative management. Probably even we would have waited for another 10 days before we did any intervention.
And are there any, in your reports, are there any cases where waiting too long caused any problem for the
Ma'am,
child?
there was only one report where there was actually in that patient, child had corneal ulcer because of the eversion, and their therapeutic PK was done.
Yeah, but you see, in your case, if you
Yes,
don't do even an EUA, there is no way you can see the cornea.
Ma'am, we did a
You did see.
examination by DEMAS if we, because that prolapsed conjunctiva is actually helping
Yeah,
to
it's covering
cause
the
damage.
cornea.
It's covering the cornea, and if we retract it with DEMAS, we are able to see the
Yeah,
cornea
so you need
very
to highlight
clearly.
that
Yes,
you need
ma'am.
to make sure the cornea is okay.
Yes,
and then
ma'am.
if a week, 2 weeks, 3 weeks, then
Yes,
it
ma'am.
doesn't matter so
Yes,
much.
ma'am.
No? So that is the point why, when to intervene.
Yes, ma'am.
And I think other than managing anxious parents and grandparents,
Yes, ma'am.
if the cornea is okay, you
Yes,
can
ma'am.
do. Okay, thank you, doctor.
Okay.